Okay, Dr. Rajagopal, today is going to be very interesting because we have this case that other surgeons, when they looked at the patient, they say, we cannot deal with this case. There's no way we can place these implants until you stepped in and you knew that you had another option to get to these results. So tell me, what did you think when you saw that case, and what was your the process of your thinking?
So, thank you, Claudio, first of all, for having me here. And secondly, coming on to the case directly without wasting much time. These are one of those cases which actually, if you see the X-ray and the CT that we had gotten done for the patient, there's hardly any bone which is present in the maxilla. It's a highly atrophic maxilla. In these cases, there are a variety of options available, and most of them being those that will have to wait. We will have to wait for a very, very long period of time to rehabilitate these patients, one segment at a time. But looking at this case, my entire mind frame changed a few years back with atrophic maxillas or with the mandible, when I had the power to use something which can actually condense those severely compromised jaws. And looking at this X-ray, did not give me any doubts that I could actually deliver results. This same case had been with a lot of different surgeons, and a few surgeons even attempted this case, and they were not able to deliver. So when this case came in, the first thing is you check for the amount of bone width and the bone height that you have. And the residual bone width and the height was actually the bare minimum, and one of those cases where actually you would do multiple different procedures to place implants. By using a simple magnetic mallet, we actually created our osteotomies in such a beautiful manner that we did not even have to venture out into the pterygoid space, which also we could have utilized the mallet for. We were able to actually deliver implants very stable with good torque and healthy, good bone all around it. If you can see on your X-ray, this is the post-op OPG of this patient. And we were actually able to place in 8 beautiful implants there. And in the near future, it's just a question of giving the prosthesis on these implants. It is actually the magnetic mallet which simplified my work so much. The only thing I had to probably do was a little bit of guided bone regeneration in some places. But other than that, the routine osteotomies with the help of the mallet made my life the
Let
easiest
me
as
ask
possible.
you. Let me ask you this question: did you split also the maxilla, or did you just work with the osteotomes and work by expansion and condensing?
So to expand, you need a little bit of bone. You need minimum 3 to 4 millimeters of bone even to expand, right? And the maxilla, suppose in this case we're talking about, is actually like a triangle. The apex, what we see on the alveolus is going to be pointed and sharp, and that is because of the severe atrophic pattern of the maxilla, while the base will still have some amount of bone. And if we can utilize the tip from the alveolus reaching down to where we have bone, we condense it further, further, further. But if I split that bone, which is already at a bare minimum, I am going to lose a fair chunk of bone. So instead of actually going in with a split, you condense and osteotomize within the amount of bone that you have without losing a speck of it. That will empower you to actually place an implant with good stability, and that is what I did in this case.
So the entire procedure, surgical procedure, was it a long one? How long did it take? That I'm curious about.
The entire procedure, you have the video playing in front of you. With the help of this beautiful mallet of mine, which I use for my patients in these severely atrophic cases, this entire procedure did not take me over 1.5 hours to finish from start till the end. That included the amount of the GBR that I did. This is the picture when I opened up the flap. Now look at the amount of bone that you have. You actually have to just magnify and zoom in to find bone. And these are one of those cases where if you're not well equipped with something like a mallet, it can go the wrong way. Because then the very little bone that you have, you're going to lose. And if you lose, you're just going to keep augmenting without new bone formation being stable and able to hold the implants. So in this case, as soon as we opened the flap, the only thing that we used is actually the osteotomes from the mallet, with the mallet, and straightforward implant placements with healthy bone all around the implant. That was the most important.
Well, I can tell that when you open the flap, you see that reduced amount of bone. More than one person might wonder, okay, is it the case to place implants today or we need to wait? Uh, we can say that with this new technology, we have been able to raise the bar or of what
Absolutely.
is possible to do in one step
Yeah.
compared to what was possible before. So that is a great advantage both for the surgeons and for the patients, right?
Absolutely.
What was
Absolutely.
the, in terms of patient compliance and post-op, did you get some feedback from him or her?
So the post-op period was actually quite uneventful for the patient. The patient had actually no complaints. We do put the patient on, since it's a long surgery, there are multiple procedures done. The number of and the amount of painkillers that the patient is on was actually negligible. The patient stopped having painkillers on the second day of surgery, even though he was advised to take the painkillers SOS if required. And believe you me, third day onwards, I actually had to call him up, and my clinic got in touch with him that how are you doing, and the follow up was in 3 days time. The tissue healed so beautifully. There was no pain that the patient had. A simple, straightforward case. It felt like a very easy case when the patient came back in the follow up. It was actually totally uneventful. There was no pain. There was hardly any swelling. And if there is no pain and swelling, obviously your patient is going to be happy, right? And that is how our patient was in the post-operative period. So yeah, did
Very
well,
well.
went well.
So I think that the input by showing this case is that, like I said, we raise the bar on what is possible and how it's possible nowadays to deal with very atrophic ridges. Uh, of course, you have a long experience as a maxillofacial surgeon, and you have a long experience with the magnetic mallet because you started, a few years back. And now that OsseoTouch is in India, you are one of the first one that we wanted to involve to plan for a program of education because it's going to be beneficial to everyone to learn what is possible nowadays to do in implantology. And so, tell me a little bit what kind of education you're going to provide and what is your idea of education in this case?
So, first of all, implantology is one of those major topics where you're actually rehabilitating those patients who have been devoid of barely being able to eat food. Giving fixed teeth is the ultimate aim that every dental surgeon is actually aiming for. And in those patients who do not have the opportunity to get implants, or their jaws or their bones are not supporting them, something like this is actually revolutionizing every bit of implantology. Why should a regular dentist or an implantologist not be exposed to the knowledge that can benefit their patients in giving the best possible treatment options? Because if we went, like the case that we showed before, if we went with any other options, we would have ideally had to do bone grafting or GBR at multiple different locations, wait for 6 months for new bone formation. Even then, we would have had compromised bone, then place the implants, then wait for 4 months more. So we've already reached a year. by the time the patient might get teeth, might, when I say might, I mean it, because guided bone regeneration, you have no control over how much bone is actually going to form. But in this case, when you had enough bone and we were able to place implants, we know in 3 to 4 months' time, even after doing a grafting, in 5 months' time, I take a month extra, I will have excess bone all around my implants. And I can actually reduce the time of giving the prosthesis by almost 6 months. Why should a regular implantologist not be given access to such a beautiful technology which can actually empower them to help their patients out? And in our training modules, we will focus on not just didactic learning, but also keep it with hands-on so that they get practical exposure, not just on dummy models, but even to some extent on patients as well. They can come in and assist us. They can do an individual procedure according to the grading and the kind of experience they have. We don't mind giving them an individual hand on the mallet as well, and what all options they can actually use the mallet for. Because having this technology, the world is at your feet to actually move forward to a next level. And and I'm sure that we will be able to deliver good quality training to most of the doctors who would want to come and actually take this to their own practices. So yeah, it will be a complete module, and we'll keep it in a way that we are able to impart, educate, and train them in a way that they can start the next day after the training.
Well, as also touch, I can only say that we really look forward to start this educational program in India with you. And, you know, thank you very much for your time
Real
today.
pleasure.
It's been,
Real pleasure.
it's been really, really interesting. Thank you again.
Real pleasure. Thank you. Thank you for your time.